Okay. I would like to introduce Dr. Hodges-Crowder. Here she has been nice enough to come give us grand rounds. She's a Louisiana native with 17 years experience in nonprofit and for-profit behavioral health care business management. That's my fault, and I apologize. She was trained as a scientist practitioner in counseling psychology with emphasis on neuropsychology and diagnostic evaluation. Her professional focus is in clinical program development for adolescents and adults, program improvement evaluation, and governing agency compliance monitoring for medical model behavioral health programs. She has developed, implemented, and supervised programs in social detoxification, intensive residential addictive disorders treatment, corporate drug-free workplace, and outpatient behavioral health care milieu in Florida, Georgia, and Louisiana. She's currently the Residential Services Director for the Council on Alcohol and Drug Abuse of Northwest Louisiana, which is now part of where you all go as your adolescent medicine rotation as well. So I will not delay this further, and I will let you start.
Thank you so much.
Welcome.
Good morning. I'm pretty loud, so I think you can probably hear me without the microphones. As you said, I'm Dr. Hodges-Crowder. I'm a psychologist with an extensive history in statistical analysis and scientific investigation, so I'm a little different than the average psychologist you might run into. I have grown up in a world of medicine that is constantly changing, moving into evidence-based practices, so I spend a great deal of time and energy learning about how we can best serve our patients through those models and teaching other counseling clinical people what that means and why it's important. Okay, that's basically what I do. So currently I am the Residential Services Director at CADA, which is the Council on Alcoholism and Drug Abuse of Northwest Louisiana, so that's why we call it CADA. So I have to say that every time. And we provide a range of services. We have a whole continuum of care, actually, for treatment of substance-related disorders, both outpatient and inpatient. Our residential services program currently I have a 70-bed facility in Bossier City, which is where my office is located. That facility houses 4 different programs for adults, one of which is a program for women and children. One of the greatest barriers that women have to obtaining any kind of mental health or substance abuse type treatment is that they have children that they have to take care of. So we actually have a model program in Louisiana where women can come with their children and stay in residence and get family treatment for the impact of addictive disorders and hopefully break that cycle of addiction for those children. We have a medical detox program in our Bossier building. We detox from alcohol and opiates. And then we have intensive residential treatment for adults in Bossier that is what everybody typically thinks of as that old traditional 28-day inpatient substance abuse treatment program. It's now called residential instead of inpatient. It is a medically monitored program. Dr. Paul Wilson is our medical director. A wonderful man. He's very experienced in the treatment of opiate addictions and helps us take care of our patients very well. We also have a low-intensity residential program, which is that typical halfway house, it used to be termed a halfway house, where people can stay in residence, have some support services, and go out into the world and become productive members of society again, and then stay there in the evenings with clinical activities and access to 12-step recovery activities in a safe environment so they can gradually work their way back up to being responsible, productive citizens. Okay? And the other residential service that we provide is with our adolescents, which is how I ended up getting involved with you guys. We have an adolescent treatment program that we've had in our community since 1989. It is only one of 3 programs in the state of Louisiana that will provide treatment to children who have substance-related disorders. Okay? Let me say that again. There's only 3 programs in the state of Louisiana. Okay? and my maximum census in that building is 16. So you can imagine that we have a waiting list on a regular basis, as do the other programs in the state. And we do a lot of services for children from all over the state. So we also have our outpatient counseling facility, which is located at 2000 Fairfield Avenue. That's our main office. And we do everything from individual counseling to intensive outpatient services for substance-related disorders. Okay. So I was asked to come here and talk to you today about, let's see if I can see how I turn it around right, wouldn't it? To talk to you about how to get your patients connected to services when a problem is identified. Which is, there's a big movement in our community now, in the medical community, to start integrating services, and I'll talk a little bit more about that. But just so you understand the scope of the problem and why you're being forced to work with us and understand this sub-patient population, I wanted to show you some of the information that we have that's current. The National Institute of Health does surveys throughout the year to watch trends. And what we know from the last 12 months is that, and this is a self-report data collection system, so you've got to consider that we may not be capturing all of the data, but this is what people are willing to admit, okay? So 9% of 8th graders, that's 13-year-olds, admit to using alcohol in the last 30 days. 13 years old. The 15 to 16-year-olds, there's about 23% of them that have used it in the last 30 days. 12th graders, about 37%. Tobacco use is actually going down, which we're excited about. We have a very, very aggressive tobacco education prevention campaign in the state of Louisiana for many years, and it appears to be working. We have fewer and fewer new cigarette smokers and smokeless tobacco users. However, we have an increase in the number of children that are using e-cigarettes. Okay, so part of health and wellness education for pediatric patients, children and adolescents, is to understand that e-cigarettes are nicotine. Okay. And it is an addictive substance as well. So we're seeing an increase in that in the use of e-cigarettes. Cannabis, marijuana abuse, and prescription misuse. Prescription misuse in this category includes any kind of amphetamine, Adderall, ADHD meds, and opiates. Okay. So those numbers have remained stable over the last couple of years, but there's a trend that you can see just from this graph, this chart, that the older kids get, the more likely they are to begin to use illicit, illegal substances. Okay, so that's something that we have to pay attention to and understand that the younger a child is when they start using a substance, the more likely they are to develop that dependency issue that leads them into a clinically diagnosed substance-related disorder. The other issue is that the younger they are, when we can start to intervene, the better chance they have of overcoming that problem, moving on, and not becoming a long-term substance-dependent individual. SAMHSA, which is a very important organization to those of us in the treatment world, Substance Abuse and Mental Health Services Administration. They do a lot of the data collection in the United States regarding any kind of Axis 1 mental health diagnosis. And the most recent data they have available right now is from 2013. 1 in 10 youths ages 12 to 17 had a major depressive episode in the last year, and only 38% received treatment that year. Okay. Now, I think the number said something like 84% of those children had seen a doctor at some point in the last year. Okay. That's a very sad number. that this many children are suffering and not getting the treatment needed. We also know that of those 1 in 10 youths that are having those major depressive episodes, at least 1.4% of them have this co-occurring major depression and substance use disorder. So they've got a double whammy going on, and there's only about 38% of them getting treatment, okay? In our region of the state in Louisiana, and we're in Region 6, and we service, I think there are 8 parishes in our region. So trends in our state that are state-specific are actually related to the different regions of the state. In this region, in our residential program and the others, the primary substance abuse is cannabis, marijuana, then alcohol, and then opiates. I will tell you that I have 14 children in residence this morning, and 3 of them, ages 15, 16, and 17, are all IV heroin users. Okay? It's a pretty large percentage of the number of children that we serve right at this particular moment. That is reflective of the trends in South Louisiana. In the New Orleans, greater New Orleans area, moving up towards Baton Rouge, has one of the highest heroin use rates per capita in the United States. Okay? So that's kind of an untold statistic that we are really trying to force people to pay more attention to. It's very difficult to treat a 16-year-old with an IV heroin problem because a 16-year-old thinks like a 16-year-old and doesn't understand long-term impact. And they don't understand the devastation that their body is experiencing. They know they feel really bad and they don't like it, but their comprehension levels about some of that stuff is not completely there. So it's very difficult. And detoxing from heroin is not pretty, and there actually are no detox programs for adolescents in the state of Louisiana. Okay? So you will see children coming into the emergency rooms detoxing from opiates, heroin, pills, because there's nowhere else for them to go. And we are petitioning the state Department of Health and Hospitals vigorously to change that, but there aren't any now. Okay? And there are only a few for adults. And with the number of heroin users in our state, it's trickling up this way, and it will become a major problem eventually. Okay? So why do we have all these kids that are undiagnosed? Well, a lot of times when children are having problems related to mental health issues and substance abuse, they're having behavior problems. So they get in trouble for violating society rules, okay, and get labeled as incorrigible or ungovernable or defiant, and are put through a legal system or into a punitive system within the school system and don't really get the evaluation and assistance that they need. And sometimes parents will go in, to the medical appointments with their kids and just complain about how awful their kid is acting, and just focus on those really negative behaviors and don't give the full story. So that's one of the things we're going to talk about, how you can help these children as they come in to your practice and to your clinics. A lot of children with managed care have trouble getting to specialists. Okay? You may not feel that right now because I'm sure you're overloaded in your clinics and in the work that you're doing. But for those of us out in the trenches and working with kids from all socioeconomic backgrounds, it is very difficult to get psychiatric care for children these days. I have several children on waiting lists to see a psychiatrist 3 or 4 months from now. So the question becomes, what do we do for them? Okay? And I forgot to mention that Dr. Lee Stevens is our adolescent psychiatrist that works in our program. And I've worked with Dr. Stevens over the years through Brentwood. I did psychological evaluations over there for years, and at Promise Hospital. And he is truly a decent human being and a good doctor. He cares about the kids, and he spends a lot of time working with them, and we were very fortunate to have him. As a matter of fact, I begged him for about a year before he finally came to work with us. But even though we are graced with that option during our residential service provision, once the children leave our care, they have to have somebody on the outside manage their medications and supervise them, and it's very difficult to get them connected quickly. One of the biggest problems that we see is that from the data that was collected through the American Pediatric Association, the National Institute of Health, SAMHSA, several other agencies over time, is that primary health care settings, emergency room settings, clinic settings, are a good place to capture some of these individuals, some of these children that are not getting the care that they need, or who are waiting too long to get care that they need. So there has been a big push in our system over the last several years, and it's going to get even bigger. I don't know if y'all are experiencing any of this or not within your system, to start integrating all of these services and having the primary care providers evaluate for mental wellness as well as physical wellness, okay? And especially with children and adolescents. Because as I said, we know that the younger a patient is, when their illnesses are identified, the better able we are to treat them and prevent them from having lifelong problems, okay? So integrated primary and behavioral health services. This is actually a department in our government that's doing a lot of research and going to be sending a lot of information your way over the next few years, okay? Their goal is to evaluate patient needs from a physical and mental wellness perspective, okay? And the two primary things that they're asking people to do to integrate into their practice is to screen for potential substance-related disorders and other mental health issues during routine medical services. Now, if you don't have much experience with substance-related disorder treatment, it's a strange marriage between treatment for addictive disorders and mental health treatment. Okay, for many years, when I first started in the early 90s working in our community, everything was separate. If you had bipolar disorder, you went to the mental health clinic, and if you had a drug problem, you went to the Office for Addictive Disorders. Everything was separated, and there was nothing that met in between, okay? So we had people running back and forth. And of course, you know as well as I do that you can't treat an illness in absence of treating anything else that's going on with that patient. Everything has to be treated together, and there has to be some coordination of care, some discussion, and it wasn't happening. And that really was a national trend, and we felt it a little bit longer in Louisiana than in other places. We started correcting it. But we still have this system in place where substance-related disorders are not considered the same as other mental health issues. Let me give you an example. Brentwood Hospital is one of the only psychiatric acute care facilities for children in the state of Louisiana. It's right here in Shreveport. It's a great facility. It's got a lot of beds. It takes Medicaid. It's got a lot of benefit to it. But if you have a child, regardless of the age, apply for placement, psychiatric acute stabilization, and their primary identified illness is drug-related, they won't take them because they don't do substance abuse treatment for children. It's kind of counterintuitive, isn't it? Because any any substance-related disorder, whether it's a cannabis use disorder, opiate use disorder, any other substance use disorder, and we have a lot of other substance use disorders these days with children abusing over-the-counter medications and smoking synthetic marijuana and different things. They don't really fall into any of the other drug categories. If that's their primary identified illness, they're not going to get treatment in that acute psychiatric care facility, okay? We are fortunate at CADA to have the psychiatric evaluation services available to us so that if we have a child that is having substance-related problems and they have a co-occurring disorder, bipolar disorder, major depression, ADHD, anything, we can evaluate and stabilize them as we're providing treatment. And we teach them about mental health wellness from a perspective that everything must be treated. Your drug use, your depression, your tendency to upset people and to be defiant, all of it can be treated together and should be treated together. But that's not always the case. And if we have a child that is actively psychotic, suicidal, homicidal, we have a concern for their safety, we have to send them to acute care psychiatric services because at that point they can no longer participate in our treatment. They must be stabilized and come back. So it's a kind of a weird situation with that. So hopefully with you guys starting to screen for potential substance-related disorders and other mental health problems during routine medical services, children won't have to get to that point. Because we'll be doing prevention at the same time we're identifying problems. And it is, without a doubt, very effective. It takes very little time. And the whole staff can be involved in the process so that the doctor does not feel like she is overwhelmed with one more thing that has to be squeezed in to that managed care system. Okay? I don't know about you guys, but we get a lot of unfunded mandates with decreased pay and less time to do it in. Are y'all familiar with that yet? You will be if you're not. So don't get frightened about screenings. They're not horrible, and they're actually a part of treatment that is really rewarding because you can see effects of your care in every aspect of the child's life. Their health improves, the family gets some assistance, and they get more consistent with their medical care. They show up for appointments on time. You don't have a lot of no-shows. There's all kinds of neat things that happen with this. So when we're dealing with children, as you know, we always have a caregiver involved, whether it's parents or guardians, foster parents, whoever it may be. So these screenings are done in conjunction with someone who can give some collateral information, okay? Because children, teenagers especially, always aren't as truthful as we would like them to be, which is one of the great things about you guys, because you can just give them one of those UDS, evaluations. You can just get them to go ahead and have that little drug screen test and see if there's anything in their system, and see if what they're telling you is matching up with what the data is telling you. Okay. So the screening options are infinite at this time. Okay. As I said, this is a fairly new movement. We have some things that have been in place for adults for a long time, but adolescents not quite as long. We still have about 30 years or so worth of data on them. So I always encourage people to move towards evidence-based instruments. They're generally pretty reliable with good specificity, and they are short and sweet and to the point. Okay. The instruments that are designed to be used in pediatric primary care are very easy to to fill out and very easy to interpret and process. So the American Academy of Pediatrics Bright Futures program is actually a really good program. I don't know if anybody's had any time to look at that or have experienced any settings where clinics are using it. But a bunch of pediatricians got together and figured out these are the things that we need to use in our everyday practice. Okay? And it's presented as a wellness program, which it is. And there are a number of key factors that are assessed for in this process. It's not just about screening for substance abuse or mental health problems. It's also about medication compliance and looking at home environment situations, asking caregivers if they need any help with anything. And they have these really great little one-page sheets where caregivers can just go through and circle answers, and you can look at it. It can be scanned and put into the medical record, and you can look at it while you're standing there typing your notes and talking to them, just like you look at any other lab result. Okay? So it's a pretty neat program, and it's one of those situations where it's good, it's recommended. A lot of people across the United States use it. You don't have to reinvent the wheel; it's already there for you. Okay? So it's very specific to your practice and to your patient population. A couple of other things that are used pretty frequently outside of the pediatric setting, but also can be used for the pediatric setting. I'm sure when you were in your basic medical studies, y'all hopefully heard about the CAGE screening questionnaire. Okay? It's been around forever and ever, and it is reliable. It's quick and dirty. I think it's 5 questions now. It's been revised several times. But it also can be used with adolescents. And there is there are a percentage of children who begin drinking alcohol around age 8, okay? So the patients you guys are working with are not too young for these questions. And unfortunately, some of that has to do with parents being inappropriate, alcohol being available, and impulsive children doing anything they can to try something new. Okay, so that can be done even with 7, 8-year-olds. Okay, the National Institute on Alcohol and Alcoholism has the Alcohol Screening and Brief Intervention for Youth, a Practitioner's Guide. Okay, I encourage every single one of you to go to their website and download a copy of that Practitioner's Guide. Okay, it's free and it's fabulous. It actually has a flow chart of how to implement a screening process into your practice. It's wonderful, easy, and time-tested. It's great. Okay? And you know, sometimes the problems that the children are having may not necessarily be their substance-related issue. It may be their caregivers. Okay? But it negatively impacts them tremendously. And you'd be amazed at what kids will tell you if you just ask. I'm sure you've found that out. And I've been working in social services for well over 20 years now, and I still get surprised by things I hear sometimes. So they will tell. So the American Pediatric Association and NIDA and SAMHSA want to make it very clear to everybody that you have multiple opportunities for screenings. And that brochure I just mentioned actually lists how to work the screening process into your regular required visit schedule, okay? You know, children who are on Louisiana Medicaid, the CHIP program, have to have a physical every year. They have to see a pediatrician every year, whether they want to or not, in order to keep their benefits. So every child in the state of Louisiana on that program will run into a pediatrician at least once during the year. Okay. So there's opportunity to reach every child in our state. We can do it during annual exams. We can do it during acute care visits. We can do it during emergency room visits. Basically, anytime you interact with a child for any medical reason, incorporating mental wellness checks should become a part of the routine. Especially focusing on children that we already know that are at risk for substance-related problems. Okay? We know that children who have learning disabilities are 4 times as likely as children who don't to abuse substances. We know that children who have impulse control disorders, all of that frontal lobe dysfunction related to attention deficit hyperactivity disorders and impulse control, explosive disorders, anger outbursts, all of that kind of stuff, they're more likely to experiment with drugs and alcohol. Much more likely. They also, in the United States, we have an extremely high rate of children diagnosed with ADHD and bipolar disorder, but ADHD in particular is of concern because these children are getting prescriptions for amphetamine to manage the symptoms. And when you have a child that has a true ADHD problem, there's nothing that works better. And I've seen lots of them that would not function ever without it, okay? But I've seen lots of them that just find behavior modification management training and a little attention without medication. But any of those children who are taking those types of medications are at risk. Their neurochemistry is not finished. They are still developing. Their brain is still growing, and so we are putting it at risk for developing substance-related disorders with chronic amphetamine use. Kids who have chronic illnesses that may be due to a lack of attention from a caregiver. They just let them get really sick before they get them to the doctor, are at risk because they feel bad a lot. And they watch the grown-ups in their world drinking things, and they laugh and they play and they take pills and they feel better, so they start looking for something to feel better too. And children who grow up in homes where their family are using drugs, learn how to use drugs very early. It is not uncommon for me to talk with patients who started smoking marijuana at age 8 or 9, or that had somebody put some beer in their bottle to put them to sleep at night, okay? And I don't know how many of y'all are from Louisiana, but it was not uncommon. I grew up in the 80s, okay? So I was born in the early 70s, and it was not uncommon in my world. I grew up in a farming family. My great-grandmother would make toddies with bourbon and honey when you had a sore throat. You know, I mean, it wasn't unusual at that time. Of course, somebody waving at me. So, and it works. Yeah, it works. And if you had a colicky baby or a fussy baby that wouldn't sleep, you could take some bourbon and rub it on the bottom of their feet and get their feet warm and massage it, and that bourbon would soak into their feet and they would calm down. You know, I mean, I've seen people do that in my lifetime. So, and I'm not that old, so these are cultural issues that you have to remember that you may be dealing with in Louisiana. There are a lot of subpopulations that are at risk for problems. The primary issues that you're going to be looking for is any guardian complaints about behavior changes, okay? When a parent says to you, when you're doing an annual exam for, you know, football practice, a physical for them to be able to be on the cheering squad, or just so that they can keep their Medicaid, whatever the reason, and the parent's saying, oh, you know, her attitude's bad, but, you know, she's a teenager, what do you expect? You know, or, you know, he's he's fighting a lot at school, but boys are boys, you know. If you hadn't heard it before, I'm here to tell you the truth, and the truth is that being a teenager is not a horrible, difficult experience, okay? Being a teenager is an exciting time with some ups and downs and emotional reactivity, okay? Because everything's new and the hormones are going, and everything's a big deal right this minute, and 2 minutes later it's not, okay? But that doesn't mean that it has to be a struggle. So when children look like they're struggling, something's wrong. Something's wrong. That's a big flag that the screenings are needed. Moodiness. Moodiness is one of those symptoms that could be 1,000 different things, but it should be a flag. School-related problems, children that are doing fine in elementary school and then all of a sudden they hit high school and they're not okay anymore. They did great in elementary school, middle school, they're not okay. The majority of children that are trying drugs for the first time, drugs and alcohol, are trying them in the 7th and 8th grades. That's middle school. That's 11, 12, 13 years old. Okay? It's much easier to get some pot than to get alcohol, than to get cigarettes. It's much easier to take some pills out of grandma's tablets and have it. And they do that. I have the privilege of coming back and talking to y'all sometime in the next quarter, I don't remember, about the trends, a little more detail about the trends in drug use in this population, because it's important to see that. If you got a particularly defiant child, very agitated, very angry, you know, those are always flags that you've got some sort of mood-related problem. You know, I've seen lots of data over the years about mood disorders in children versus anxiety disorders versus kids just growing and changing and adjusting. You know, there's some conflicting information out there, but I can tell you that it is true that children with depression problems present differently than adults. Okay? Children with depression are generally agitated and angry. They're not sad and laying in the bed crying. Okay? They're very, very agitated. As a matter of fact, when I first started school years ago, we actually had a diagnosis called agitated major depressive disorder. And it's gone away. The psychiatrist decided we didn't need it anymore, but it's a perfect description for children. They get very agitated and angry and irritable, and it looks a lot like defiance. But it's a mood problem. Got a lot of anxiety problems with children these days too, because they have a lot of pressure. Growing up in a world that's available at your fingertips 24/7 is pretty overwhelming. So that's actually part of the pediatric program that you can put into your practice that asks caregivers and children about screen time and modifying those activities as part of a healthy lifestyle. Because it does make a difference, okay? So, we've been talking about how important screening is and why the powers that be and the researchers and everybody's decided that primary care settings and emergency room settings and clinic settings are the best places to start the screenings now, instead of waiting until there's a problem and sending them to those drug treatment people or to those psychiatrists or that mental health place. Let's try to help them before they get to that point. Then you have to figure out what the treatment resources are, because who knows unless you've had a problem and had to send somebody there, right? Well, hopefully, those of us that are in the treatment arena are doing a better job these days, because we didn't used to, of getting the information out to the public. And we have more government-sponsored campaigns now about suicide prevention, depression in children, drug use in children. So it's a little less taboo than it used to be. But you know, you still have to do a little legwork. This is one of those great things that, you know, if you're in a practice or in a clinic with other people and you join it, you know, they don't already have that in place. There's a whole lot of people available to help take care of this. You can even call somebody like me and I'll come right over and help you. Okay? So, it's not a difficult. The Department of Health and Human Services, Department of Health and Hospitals, however you want to call it these days, has a fabulous website that lists by region of the state, by city, by parish, what services are available for mental health treatment, for substance-related disorders treatment, and which providers do both. And the state actually has mental health clinics for children where they can go and see psychiatrists, and you may wait 3 months to get in. But the system has improved, and just in the last couple of years it's improved, because you used to have to wait 3 months for the appointment to see the psychiatrist. Now you're waiting 3 months for the appointment to see the psychiatrist, but you can actually see a clinician within a week or so. So it's getting better. I'm not sure how they're managing that when they have a kid in crisis, but
Who is the clinician that sees them? Are they psychologists?
They're generally LPCs or social workers that are trained. I'm sorry, licensed practicing counselor.
Okay.
In the state of Louisiana, you have several different clinicians. So licensed practicing counselors in LPC, you have licensed social workers, you have marriage and family therapists. They traditionally don't work in substance abuse treatment, but you actually also have licensed addiction professionals who, there are degrees that you can get specific to substance-related problems and prevention. So you have licensed addictions counselors, and then there are counselors in training in all of those arenas. The psychologists generally are doing the assessment, evaluation, or working with a psychiatrist for med checks. So they're not doing a lot of the one-on-one treatment anymore. So DHH has a great website. You can look that right up. You have nonprofit consortiums, continuums of care. Okay, these are fancy words for saying that all of us that work out in the community are working together to make sure that you have single points of entry into any level of service within the community. The organization I work with, CADA, it's been in our community since 1958. By the way, we've been doing this a long time. We provide several different levels of care. You can call any of our numbers and get information and get sent to the right level of care for discussion. You can get in to see us pretty quickly. We have, I'm trying to remember the name of it, the Child Wellness Board, I think now, that is with regional activities, and DCSF, Department of Children and Family Services, is involved in that, making sure that everybody knows what everybody else is doing and can get referrals going. Insurance providers actually have resource lists. That's a great thing for, you know, the office manager, the medical assistant to have available. Any insurance board that you're on as a preferred provider has those materials, not just for the professional staff, but they have materials that you can get for your patients. And there are other people working in this community who are glad to tell you how they've taken care of problems in the past. And it's been my experience over the years that if we're not working together, then a lot of patients suffer. So it's really great that we have the opportunity to get everybody together nowadays. So this is what the pediatricians, the The association recommends this is what you got to do. Prepare to address substance use and mental health issues as part of your routine practice. Have a procedure in place for the screening process. Whoever is in the office, the clinic, has a role to get that information collected from the patient to make sure that it gets to you in a timely fashion so that you can review it with them. And that if there is an identified problem, the referral information is right there, okay? You don't have to go out of the room and hunt down some stuff in the room 5 doors down or in the other building, you know, and when you come back, the patient's gone, you know, those kind of things that happen. There are plenty of free pamphlets, free lists, free materials available that can be put in patient rooms in the lobby, and referral documents that can be readily available that can be given to the patients on their way out with their bill, right? So it's very easy. It's very easy. And if it's a situation where it demands that you assist in getting them into that care level that they need, there's somebody designated in the office that helps with that. You have a nurse case manager, you have a medical assistant, somebody that can do that. SAMHSA, Substance Abuse and Mental Health Services Administration, gets a ridiculous amount of funding through the government to print brochures, okay? And you can order 100 of them at a time. And they have all different kinds of brochures. They have brochures for adults, for children. Is my drinking a problem? Is my drug use a problem? You know, I feel bad. What can I do? Talking about depression, anxiety, different things like that. There's all sorts of things. There are webinars you can show office staff, support staff, that are free, and they actually get continuing education units for them that talk about population-specific screening and problems, how to identify problems, how to address it. And if somebody doesn't want your materials today, and they're a patient with you, most everybody has to have a primary caregiver now. It doesn't matter what kind of insurance you have. Or if you don't have any insurance, I mean, your options are limited. Which, by the way, children in Louisiana, nobody in Louisiana should be without insurance if they're under the age of 18. Actually, 21 now. Everybody can get insurance. So if you have a child that's a resident of Louisiana that doesn't have any insurance, it's a wellness problem. Somebody dropped the ball, okay? Can't guarantee that reimbursement rates are what you want, but you know, it's available to them. As a doctor, as a pediatrician, it is your responsibility to provide the care that each child needs. When they come in, they're looking to you as the expert to help them. And this is another component of that care that you can provide. And if you don't know the answer to the question, there are lots of people that are willing to help. It is my job to help, and I'm not the only one. So this is the way that our world is moving. And I suspect that 10 years from now, pediatricians are going to be doing a lot more, pediatric specialists, I should say, and pediatricians will be doing a lot more mental wellness and physical wellness treatment together, because that's the way it's moving. And there's a lot of primary care doctors that do that already. And you know, I don't know, there's a lot of people on both sides of that, you know. But if the problem is there, the resources are available to assist these kids. So I'm real excited about the opportunity to talk about this kind of information. I actually worked in psychopharmacology here when I was in college, and I've been able to come and do a lot of education lectures over the years here for all different people. I was just joking. I came over to talk to the nurse case managers yesterday about psych patients and how to refer psych patients to us. So I'm around. So I'm always available to answer questions. And if you guys have any questions, we've got a few minutes.
This phase of evidence-based medicine, there's got to be evidence that it works. So the question is, let's pick a specific, say opioids. Somebody who's been on opioids when they come to you. What's the chance of getting them off and keeping them off for a significant period of time? I would define, say, 2 to 3 years. Is this fraught with problems, or can we be fairly successful, or are we just...
It is fraught with problems.
What?
It is fraught with problems. Yeah, it's very difficult. The data shows that for any kind of long-term abstinence from opiate use, that we have to have a twofold approach. We must do medication management of withdrawal and post-acute withdrawal, which could be up to 18 months after they stopped using, of their symptoms, because the symptoms are so overwhelming and debilitating. I mean, they've been putting this opiate into their body all this time. It's not
The
working.
nitty-gritty question is, assuming you people can do what you can do and so forth, what is the outlook? Can you get half of them off the drug all the time, or we talk like 20%? Or are they going to be like poor in the body where they will always be with you?
We have post in Louisiana. Let me finish the other question. We do the medication management along with behavior modification training, the two together for any mental health illness. You're going to get all kinds of different success rates in Louisiana depending on who you ask and where it comes from. Statistically, nationwide in the United States, you have about a 38% success rate with the first course of treatment. Long-term abstinence, which means 2 years or more. Okay. The average addict, opiate user, will go to treatment 4 times before they maintain any long-term abstinence. Okay. So that's why we're moving towards harm reduction therapies with that, and we'll talk some about that. I'll see you next time. Because there are ways for people to improve their quality of life, be successful contributing members of society, and reduce their drug use.
How often does any sort of success do the patients just drop out of your treatment?
How often do they do that?
Do you have as much a no-show rate as I do in my clinic?
No, not for residential treatment. And the reason for that is,
There's a minute.
well, it's because there's so few options available, okay? I've got a 28-bed residential treatment program for adults, and there are 3 others in the state of Louisiana, and I've got at any given time a waiting list of 50+ people, okay? There are not enough beds for everybody in these treatments.
They may not, but how about after what's the magic days, 28 days or 30 days, when they go out, how often do they get lost in there once they get out?
It's about the same recovery percentage. It's a little bit less than 50% for the first treatment episode. And the way that we try to combat that is to continue their care once they leave residential treatment. Because it used to be that people would just go inpatient, they're magically cured, and they go on, or get kicked to 12-step recovery programs, and that was it. We know it's not working. So you move to a lower level of care. You go to intensive outpatient, you go to counseling, you have a support service network so that those habits can be established and maintained long term. Does that answer your question?
It seems to me you have to be polyamorous to get into this psychology.
That's funny you say that, because I think most people consider me a pretty simple person. I think that's funny, because most people consider me a pretty simple person. I think that probably any of you in this room that have been working with patients for any length of time have had this period where you get pretty despondent because nobody's taking their medicine like they're supposed to. You know, they don't show up for their appointments when they're supposed to. You know, your blood sugar's 600, and you come for your appointment last week, and when you have this problem, or you're drinking alcohol, when you're diabetic, and all those problems. I think we encounter all that stuff. It's the success rates and the ability to offer solutions, I think, that keeps all of us going. And, you know, I just happen to be interested in the people that don't always want the treatment we have to offer.